Okay, so good evening, everyone, and welcome to our second ECHO session of the Enhancing Palliative Care series. I'm just going to share my screen, hopefully. And so this session will focus on symptom assessment and management, part 2. It's a huge topic, as we know, and tonight we'll be joined by our specialist presenters, Dr. Olivia Rygorowicz and Dr. Tait. Just start by our acknowledgement to country. So we acknowledge the Kaurna peoples who are the traditional custodians of the Adelaide region. We pay spiritual connections to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to their elders past and present. We would also like to acknowledge and pay respect to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel and contribute on Kaurna country. So for those of you that weren't with us last week, I'll just briefly run through our Project ECHO. It's a palliative care ECHO project of 12 months duration, an initiative to cultivate communities of practice and establish continuous professional development and networking amongst GPs and palliative health care providers across South Australia who care for patients with life-limiting illness. At this point, I'll just make mention that we do have a page on our GP Partners website, so please feel free to have a look at that. The resources, a little bit about the project and about our team is all there, as well as past presentations. So thank you. This project is supported by funding from SA Health through the Palliative Care 2022 Grants Project. And our project is being delivered to you by GP Partners Australia. The Palliative Care ECHO project is a 12-month initiative, which I've already mentioned. And Project ECHO stands for Extension of Community Health Outcomes. It's a virtual knowledge sharing network designed to create a learning loop between health professionals with the aim of increasing knowledge and access to healthcare in local communities. So just a little, some housekeeping, welcome and reminders. So please introduce yourself in the chat. Let us know where you are joining from and your role. Your microphones are all muted, and there will be lots of time during our session for question and discussion. You're welcome to use the chat function to ask questions. If you have any comments or having any technical difficulty, please use the chat, but also feel free to raise your hand. The didactic session will be recorded and will be emailed to you as we did with our first session within the coming weeks. Remember not to disclose any personal health information during the session, and we hope that you enjoy the session. So how the ECHO program will work is that the general format is that we'll do the introductions as we're doing now, and then we'll have a didactic presentation, and then that will be followed by our interactive case-based presentations and discussion. And tonight we have 2 cases. We'd love you all to be a case presenter. So if you would like to present a case or a study about a patient that you're concerned with and would like some input from our expert panel, you can let us know in the chat, or you can email at my email address, which is on the screen, or you can let us know via our website link. So the palliative care, we've got the overview of sessions, which you would all have upon registration. Some introductions tonight are on the screen, but what I think might be best if we will go around the table and I'll let my team introduce themselves. So I'm Leanne, and along with Russell Shute, I'll be facilitating tonight's session. I'm the General Manager here at GP Partners Australia and also the manager of our GP Share Care program. So now I'll just go around the table and each of our panelists and and members of the staff will introduce themselves. So over to you, Atif.
Thanks, Leanne. I'm Atif. I will be providing tech support. And like I said last time, if anything goes wrong, it's your fault and your computer's problem. If not, then credit goes to me. Naomi.
Hi everyone, my name is Naomi. I work for GP Partners Australia and I am the network coordinator for ECHO.
My name is Tait. I'll be giving a short presentation today. I've got a background in pharmacy and I work with the Rural Support Service.
Hello everyone, I'm Julian. I am currently an embedded aged care pharmacist at Sunanda Lutheran Home, as well as working as a palliative care pharmacist for the Southern Adelaide Palliative Service.
And hello, I'm Julian. I'm using the same screen at the moment, but I am Olivia. I am finishing up my training in palliative care and I'm currently working at Flinders Medical Centre.
Oh, hello folks. Russell Shute. I'm a GP and I've had a long interest in palliative care, including working with GP partners in the palliative shared care program for about 5 years. Some of you may know that, but I'm excited to be part of this new project.
Excellent. So now I'll turn over to Russell, who will be facilitating from now on, and he will introduce our presenters.
Okay, so as we've said, I'm going to be keeping an eye on chat. So any questions you've got, please fire away and we'll try and deal with them after the didactic presentations. The coin toss has happened and Paul lost the coin toss, so he has to present first. So Paul Tait, as he's just explained, a very experienced senior clinical pharmacist with Rural Support Services. So it's a great pleasure to welcome Paul. Thank you very much, Paul.
Great, thank you for having me. I'll just share my screen. Okay, so I also wish to add that I'm speaking today from Ghana land and wish to pay my respects to elders past, present and emerging. I've been working in sort of the palliative care space for just over a decade now, and when I started working, it was really, the focus was looking really at the end of life, so at the terminal phase of life, and liaising with community pharmacies to try and see if there was a way that we could improve access to subcutaneous medications at end of life. Now, Olivia is going to be talking a bit more specifically around the terminal phase today, but I'm going to be sort of giving a bit more overview of sort of where the pharmacist might fit in. Okay, so I've got a couple of objectives here, really just to talk about the role of the pharmacist, why the issue of timely access to medicines is an issue in the community, and to briefly describe a core medicines list that we developed some years ago in South Australia. So I tend to start my talks by reporting on a few numbers. So this first number, 161,300, is the number of deaths of Australians in 2020. And so we would look at maybe 15% of them being due to accidents and sort of issues like that. But perhaps half of them, using estimates, would have palliative care needs. So that brings us to about 80,000 Australians would have died with palliative care needs. When you actually look at the number of pharmacies across the country, actually, you know, they're distributed quite differently depending on whether we're in a metro or a regional area. But there's nearly 6,000 pharmacies across the country. And so when you do the maths, you actually work out that most pharmacies would have something like 10 to 12 people with palliative care needs using their services over a course of a year. So it actually makes sense to engage with them in terms of managing issues that relate to their palliative care needs. Some years ago, there was some work done by the Grattan Institute looking at the proportion of where people die in Australia. And basically, when you add up the proportion that die at their home, which is about 14%, and then those that die in a residential aged care, which is about a third of all Australians with palliative care needs, actually you see that almost half of Australians are able to be cared for and die in the community. But I guess while the other half will die in a hospital or a hospice environment, they will be cared for in the last 12 months of their life, predominantly in the community as well. So I'm going to start off with a bit of a definition here of medication-related problems. So the Australian Commission on Safety and Quality in Healthcare describes this as any event involving treatment with a medicine that has negative effect on a patient's health or prevents a positive outcome. Now, when we look at people with palliative care needs who are in the last phase of their life, they have a lot of risk factors for medication-related problems. And I don't think this is going to surprise any people present here today, but just to sort of recap a few issues, polypharmacy will be, and these are all interrelated, of course. So there's polypharmacy probably because of multiple comorbidities. There's prescribing cascades. So we've got people prescribers and people buying medicines over the counter to manage symptoms from the medicines that they're on. People, as they approach the last phase of their life, have increased risk of falls. There's obviously movement in and out of hospitals, but also transitions across to the residential aged care home environment as well, which means changes in prescriber, changes in pharmacy, and changes in the approach to care. There's obviously physical decline and cognitive decline. Now, one of the big pieces of this puzzle is the caregiver as well. And while I said at the beginning of my talk, a lot of the focus when I started out in palliative care 10 years ago was really around the access to medicines through community pharmacies. It was very much apparent that the caregiver plays a big role in managing medicines, particularly as the person's cognitive and physical abilities decline. Okay, so pharmacists, there's been a lot of literature published around pharmacists over certainly the last 5 years or so, looking at aged care and not just in the residential aged care home space, but also in a home context as well, and talk about the role as sort of predominantly a supply role or a clinical role or an education and training role. Now, it was interesting when I started this journey looking at the supply of subcut medicines through community pharmacies. It actually, one of the triggers for a pharmacy to hold a medicine was actually having an understanding of a stronger understanding of the clinical needs of the person as well. So what we found was that the pharmacies that held the subcutaneous medicines that were valuable in managing end-of-life or terminal phase symptoms actually had a greater understanding of the patient as well. This is a diagram or a figure that we developed for a publication a few years ago through the Pharmaceutical Society of Australia, and it's I'll talk you through it. So around the edge of this figure, we have what we would call activity levels, so ranging from normal activity, and you can see as they go around the semicircle that people lose their ability to like physical ability, to the point of the red part, which talks about being totally bedfast. Now, this is not news to anyone listening, but you can see as you go through those phases, there is a transition around how the medicines are managed. So first of all, there is a change in the types of medicines that are being used. So there's a stronger focus on management of current symptoms. But also, particularly if someone's in their home environment, the role of the caregiver becomes a greater role. And, you know, I sort of describe this in, you know, if I got osteoporosis and then heart disease and then a cancer, I'm in control of all of the decisions around my care, including my medicines. But there will be a point where I lose that ability, and I will benefit from having someone, either a neighbor, partner, son or daughter, helping me out with that. And suddenly they're thrust into the learning everything they can about my medicines. So the importance of the multidisciplinary team is critical here. So yeah, as we move from low level needs to high level needs, there are changes in the way that the medicines are, the types of medicines that might be required, but also the role of the caregiver will increase. So what I've done in the next slide is just sort of looked at a few different issues here that a pharmacist could potentially get involved with. So the top, I've got medication reviews. So at the moment in Australia, there's 3 types of reviews that can happen. So a meds check, which is a free in-pharmacy check that anyone can refer, so including the person or their caregiver. And certainly in practice in the past, I've used that as a mechanism to get an up-to-date list of someone's medicines when they're referred to our palliative care service. There's obviously the home medication reviews, and then there's the residential version of that, the RMMRs. Now, there's a lot of talk at the moment about on-site pharmacists and the government, the federal government funding that. And so that is going to be a game changer, really, in terms of how medicines are managed, particularly in a residential aged care home space. But I see the medication reviews as an opportunity for reconciliation. So it could be, particularly if someone has been transferred out or discharged from a hospital environment, an opportunity for the caregiver in particular to be have some education around the medicines. And so particularly if you're recommending a home medication review, to actually put on there that you specifically would like the caregiver to get up to speed with some of the issues around the medicines. And they can also obviously provide some guidance on deprescribing. There's a federally funded program for community pharmacies called the RUM project, Return of Unwanted Medications, which is about people being able to take their medicines back to the pharmacy, a community pharmacy, although some hospital pharmacies will help out with this as well, particularly in regional parts of the state. And they will be disposed of, the medicines will be disposed of appropriately. And then I talk about the medication supply side of things. So obviously there's dose administration aids, stage supply, where we can actually supply maybe a strip of a medicine instead of the entire box, if you're concerned about the use of the medicine in the home environment. Prescriber bag items. So there's a whole range of medicines within the prescriber bag, which could be used, particularly in the last days of someone's life, if you're doing home visits. And then I'll talk briefly about the core medicines list. I talk about all of this because, as I said earlier, that when we started to study the pharmacies that held the medicines that were useful in managing the terminal phase, we actually found that the sooner they learnt about, the earlier they learnt about someone with palliative care needs, the more likely they were to hold those medicines. So these are some great strategies to engage, and certainly with our when I've worked in services with prescribers, either nurse practitioners or palliative care physicians, I've encouraged them to think about getting their prescriber bag items from different pharmacies to actually send a really clear message. These are some of the medicines that we use in practice. I've got a note down there about locked boxes in terms of this might work quite well with some patients who we are concerned about their medicines wandering, either because we're concerned about another family member. And certainly I've worked with the local nursing services to actually ensure that there are locked boxes in the home if that was deemed necessary. This is just reiterating my point earlier. So just I'm going to make a comment here about the PBS prescriber bag, because this is a good way to use to send a message to the pharmacy about the types of medicines that are useful in the last days of life. I say that because a pharmacy, like a GP practice, is a business, and they have to make business decisions about what medicines they keep and what medicines they don't keep. And so many of these medicines here will have a 2 or 3 year shelf life. And so you can see if you're ordering medicines through a prescriber bag system, then that allows turnover in the pharmacy. This is a list that was published through CareSearch that some of you might be familiar with. I'm just going to throw just sort of divert a little bit of attention to the pharmaceutical benefits for palliative care. If people aren't aware of that, this was sort of set up some years back now, just to sort of think about access to medicines. So traditionally, what would happen is that the pharmaceutical sponsor would put forward the indication for a medicine, and then it would be, then if it's approved by the TGA, it would then get listed through the PBAC on the PBS. And so a good example of that would be hyoscine bromide, which would have been registered for colic. So actually it was only ever available on the PBS for colic. And then there's a lot of attention, particularly from community providers, around that being unfair, because of course, if you were to prescribe it in someone in the last days of life, then you would be using it to help with secretions, and so the prescriber was going against what was in the PBS. So there was a big push to expand on the indications, the quantities, and the availability of different types of medicines through the PBS. So here's just a few examples. I'm just going to move quickly now through some years ago, when we were looking at the issue of access to medicines. We realized that there was something like 30 to 40 different formulations that were possible for a prescriber to prescribe in the last days of life. And we realized that, certainly in a hospice environment, that was reasonable for, or a big hospital environment, that was reasonable for all of those medicines to be stocked. In an aged care home, it was less likely that you would find those total 30 or 40 different formulations available, but certainly in a community pharmacy, it was almost impossible to find medicines useful. So we aimed really at looking at sort of key symptoms that were expected in the last days of life, and build a medication list around that. So this is just how we we came up with this list of 5 medicines. We did that in discussions with a whole range of stakeholders. And the idea of this was to make available the medicines that were going to be prescribed. I'm just going to finish off now and just sort of share. When I sort of look at healthcare, in the past, I've looked at it as a very logical, linear process. And I've put on the left here around a linear process to do with medicines, obviously. And, you know, I always felt that it was about sort of focusing on the pharmacy, on the prescriber, on the person administering the medicine. And while that's important, I think we have to realize that in healthcare, actually, we're dealing with much more complex environment. And sometimes the actions that we do at one point can have quite random or unpredicted responses. And one of the things I've learned over the years is that it's more about actually how building strategies that help those interactions between the points, rather than trying to put out all of our focus into the individual points, if that makes sense. So I guess I suggest this because I think it's important, by engaging with the pharmacy earlier in the palliative care journey, you actually have already started that interaction. So rather than sending a script on a Friday afternoon and the pharmacy then having to sort of manage that side of things, hopefully by involving them much earlier, they can actually see that we have quite a cohort in that neighbourhood with palliative care needs. I'm just going to finish up now. I need to just stress that a pharmacist may not naturally know that a patient has a life-limiting illness by the very fact of them turning up to the community pharmacy, and sometimes using a flag like a medication review or a phone call to actually focus on that is important, rather than waiting to the last day of someone's life. And as I said, the research has shown that when we engage early, the pharmacist is very supportive and can actually have flow-on effects, not just for yourself as a prescriber, but for the caregiver and the person with the palliative care needs. I just need to stress once again, they're private businesses, and so therefore the focus is going to be on the turnover, although by engaging earlier, you're providing a clinical impetus to hold them, stop the medicines. As I said, we've developed some years ago a medication list within South Australia to try and improve the communication between the pharmacist and the prescriber. Thank you.
Thanks very much, Paul. That was a fantastic talk, and yeah, that take-home message at the end about really establishing that connection early. If you've identified somebody who's in that that last year or so of life, and possibly is going to need those sort of medicines to help support them in the community, is a really important point. The other thing is, we will make sure the South Australian list of medicines is, we've talked about that many times in the past in our previous iteration of palliative shared care, but we'll make sure we've got that on the website for you. Are there any burning questions at the moment? You can either pop them in the chat or come off mute if you want to. If not, I'll get on to Olivia Rygorowicz, who is a almost palliative care consultant. I mean, she's 99% finished, I think. So I will hand it over to Olivia.
That's special. I'm hoping to
absolutely
use your
all good
laptop. I'm so sorry.
It's no trouble.
And I just need to work out how to share my PowerPoint. Julian, I might need you to give me a
So
I just need to.
yeah, go there. Go to share screen.
Yeah.
And choose yours. Do you need the notes?
And
And then right, press the 2 fingers. And there should present to you.
thanks.
Yeah. Cool.
All right, lovely. So as we discussed during our last session, it might be helpful to just have a quick presentation about symptoms and the care of a patient in the terminal phase. And I just thought I'd share sort of a bit of an approach of how I might care for somebody who might be at home deteriorating and approaching that terminal phase. And I can appreciate that this might be work that is unfamiliar to some of the clinicians that have joined us, but also work that might be very familiar if you've been looking after your patients and providing home visits or looking after palliative care patients within nursing homes. So just a quick first thought about diagnosing dying, which I think it sounds simple and obvious sometimes when you see it on the page, but it can be quite complex. And certainly in the hospital system, recognizing that somebody is actually deteriorating often gets clouded by the numbers on the blood tests and different interventions and trying to reverse things. But certainly I really feel that there is a benefit in trying to recognize dying early, as it gives you ability to make a plan for the care of the patient and to communicate with the patient and their family and to really make individualized decisions and individualized plans that really align with who the person is and what their goals are. And certainly if we fail to recognize dying early enough, we risk poor outcomes, giving burdensome treatments, and really missing opportunity to provide holistic care and honour the wishes of the patient's end of life. So in terms of signs and symptoms of somebody who is approaching death, certainly their function declines and they become increasingly bedbound, and even within that space requiring extensive nursing care for things like rolling or turning or even sitting up. They might have a decreased interest in the things happening around them, eat less, and over time develop a decreased ability to swallow. The active dying phase is, I guess, heralded by a decrease in responsiveness of the patient, reduced urine output, changes in their breathing pattern, and peripheral shutdown with skin mottling. As I said, I think in our first presentation, that a lot of what we do in palliative care is working out what are the goals of care and trying to communicate this as clearly as possible to both the patient and to their families. Really, when we see somebody who's in the deteriorating phase, it's really important to communicate this to the patient and really have a bit of a balanced discussion of the focus of the care that can be provided. And certainly there might be circumstances where there are reversible causes that could be investigated, but it might not be within the patient's goals to do that, and they don't actually want to have any life-prolonging treatment. As I said before, communicate this with the patient, establish their goals, and involve the patient's family and their substitute decision makers. And really, if we do this early, it sort of, I guess there's sort of less surprise for the patients and their families. In the community, I think it is really important to update resuscitation plans, and the document that we use is a 7-step pathway, and then also to formulate a plan of how to manage their symptoms. So certainly, in reviewing the patient's care plan or creating a treatment plan, I think it's sort of underpinned by rationalising and deprescribing. And certainly there will be a lot of medications that possibly have already been deprescribed through the deteriorating phase, but when we're entering the terminal phase, a lot of these actually will be stopped just from the sheer fact that the patient can't swallow them. We rationalize things like blood tests, BGL monitoring, and doing observations. And in the hospital system, perhaps more so than in the community, stopping things like IV fluids, antibiotics, feeds, blood products, and always thinking about whether or not the patient has a defibrillator that might need deactivated. And I really hope that's been thought of before they're entering into the terminal phase. And I've popped down mechanical ventilation for some specific patient groups such as M&D. This might be part of their care plan. There is a really good document by SA Health that I'll possibly pop the link in the chat after this about deprescribing medications. I've just taken a screen grab of that. And certainly I think it provides a bit of a guidance of the medications that patients might stop being able to swallow, and I guess a general recommendation of how to manage the withdrawal of those medications, or manage the symptoms that those medications are prescribed to treat. The ones I really would like to highlight are medications such as anticonvulsants, anti-Parkinson medications, antipsychotics, benzodiazepine, and antidepressants. And really these need to be thought about, well, how are we going to replace these medications in the terminal phase? And certainly, you know, a withdrawal of an anticonvulsant that isn't replaced with something else might put the patient at risk of having seizures in their terminal phase. In terms of symptoms, a bit of a map here, but the symptoms that I like to think about and that need to be addressed might include pain, nausea, restlessness and agitation, respiratory secretions, dyspnea, dry mouth, constipation, and urinary retention. And Paul provided us that really great map of the medications that are prescribed for the terminal phase. And surprisingly, there's actually not that many. And I think that does actually simplify things, and I hope makes it not as daunting of a task to look after somebody in this terminal phase. Certainly, it is really important to think about a patient's pain relief. And often for patients with malignant disease, they would already be established on a pain regime. And as that patient is unable to swallow, we need to make a plan of how to administer pain relief in a different way, and often by the subcutaneous route. Patients won't be able to express their pain, and we need to look at other markers. And for a patient in the terminal phase, it might be that they're holding themselves very stiffly and turning them, and providing care is difficult. They might be restless, so we might see distress on their face or tension. I also just make a small point about nausea, and if nausea has been a feature of their deteriorating phase, I think it's also very important to consider how we treat that in the terminal phase. The patient's breathing can be quite variable in the terminal phase, and sometimes we see it being shallow or laboured. Sometimes it can increase in rate and decrease in a cyclical fashion, or a chain-stoked breathing, or we might see a patient having increasing apneas. And secretions is one that causes distress more so to family and clinicians than the patient themselves. But as the body is getting tired, the swallow is also getting tired, and difficulty in coughing and clearing secretions leads to that moist breathing, or as the literature horrifyingly calls it, the death rattle. Certainly, I counsel families a lot about this symptom, and whilst we do have medications to counter it, they're often not that effective, and really normalizing it as a part of what to expect in the terminal phase, I think, is the best way to treat this, and just reassuring the family that whilst this noise is distressing to hear, it actually is very rarely distressing for the patient. And lastly, a patient can be quite restless in the terminal phase and needs to also be addressed. I think I very much limit physical examination for our patients in this phase, and really sort of having focused exam and often checking peripheral pulse, the warmth, having a look in the mouth to see if it was dry. Sometimes we need to do an abdominal examination if we think that a patient might be in urinary retention. I have popped up here the guideline that SA Health has developed for the prescribing of the few medications that we need for end of life. And there's also, I think, really sort of dosing ranges suggested. And this is certainly for a patient who is opioid naive, if we're looking particularly at the doses of the pain relief or dyspnea. And that might need to be different if they are established on a pain regime already. But as you can see, there's really sort of 4 or 5 domains and not that many medications that are required. And I'll also pop a link up to this guideline. It is actually also very easy if you just Google, end of life prescribing SA Health. And very much, I like the point that Paul made, that we need to think about these medications in a way of anticipating needing them. I'm speaking to the pharmacy and ensuring that their stock is available. And I do a lot of prescribing of this medication for people who are more in a deteriorating phase, and we've made a plan to keep them at home for their end of life. And sometimes just having a very small supply, a single box of morphine and a single box of midazolam and a little bit of haloperidol will get us through, 24 or 48 hours until we can get a little bit more supply. And I think it helps prevent that mad scramble and the Friday night and public holiday dramas that I'm sure we've all been involved in. And so certainly, a lot of people say, well, this patient that I'm looking after, they've entered the terminal phase. Do I need to prescribe a Nicky pump or a subcutaneous infusion or a syringe driver, as it may be called? Certainly not everybody who is dying needs a syringe driver, but certainly it can be very useful in stabilizing symptoms and delivering medications in a regular way that provide support for pain or dyspnea or restlessness or anxiety. You can all see my scrappy writing here, but this is just a demonstration of an order via the RDNS. This is their order chart. And you can see that I've prescribed an order for a syringe driver and also our PRN medications, and very much writing down what the medication is for, the dose and the frequency. And I think it's really important to, chart according to, the pharmacokinetics of these medications, rather than, putting a dose limit, because often we don't quite know what a patient needs in the terminal phase. And often I will just prescribe the breakthrough or PRN medications first and see what is needed in a 24-hour period, and then decide whether or not that the accumulative dose of the medications needs to be added into a syringe driver. If you joined us last week, we talked about very briefly the conversion of oral medications to a parenteral form. And we talked about some various apps that can help with this dosing guideline. And just here, there's a small chart of some of the common medication that patients are on. And you can see that the dose of oral morphine of 30 milligrams accumulatively is equivalent to 10 milligrams if given via the subcut route. So, for example, if I had a patient on 15 milligrams of MS Pointon or long-acting morphine twice a day to a total dose of 30 milligrams of morphine, And if they were entering into a terminal phase and couldn't swallow that medication, then I would prescribe a continuous subcut infusion with 10 milligrams of morphine at a baseline to ensure that they have comfort and not withdraw from that pain relief. Just a quick word about some of the other things to consider. Hydration is something that families are often really, it's a point that stresses family. And I think it's also important to normalise that the inability to swallow and to hydrate is part of the normal drying process. And a good tip is to focus on mouth care, including good mouth swabs, keeping the mouth moist. And this is something that family can be shown how to do it. Also providing lip balms and oral gels and things like Biotin or Oral Balance. Food and eating and drinking is something that we always assure that a patient is able to do until they can't swallow. But very much when we're asked about artificial hydration or feeding, we reassure family that this can actually be a burden to the body who is entering into their terminal phase. And has been shown that if we provide fluids, it often leads to detrimental things like pulmonary edema or peripheral edema. And very much normalising that the functional status of the patient is declining, and thereby the patient very rarely experiences hunger in the dying phase, or they don't experience hunger in the dying phase. And by providing nutritional support, we may be causing nausea or vomiting. And just really quickly, also important to think about bladder care. Often patients become incontinent during the terminal phase, but some patients can go into urinary retention and sometimes require a catheter for their comfort. And often if you have a very agitated patient, this is something that's important to check, relieving that symptom by a catheter will help so much more than just providing benzodiazepine. And constipation is something that we sometimes need to think about as a patient is deteriorating, as being constipated can also lead to a patient's discomfort. And just thinking about skincare, regular turns, and thinking about wounds and how we tackle that in the terminal phase, and still thinking about whether or not it's appropriate to change dressings and to think about odour management for the patients who might have really tricky wounds. Something also, and I'm almost done, but just to think about the psychosocial and the cultural and the spiritual needs of the patients as we're creating a plan for their end of life. And I think this can be one of the joys of caring for a patient and their family in the terminal phase, as we learn so much about different cultures and the values. And often patients will share the important rituals, and it's always good to think about, whether or not facilitating, their spiritual needs, visits from certain spiritual leaders or providing ceremony, as this is often very important. And various cultures have different rituals after death, and it is so nice if we can also learn about these and accommodate that. And something that also needs to be thought about is a plan for once the patient has died, who might provide the certification of death, who is going to write a death certificate, and has the patient thought about the funeral arrangements. And just the thought that occasionally our patients might need to, their death might need to be referred to the coroner. And just a small word of bereavement. I know as general practitioners that a lot of bereavement care of family members falls into your domain, and very much there are, I guess, limited services to care for our bereaved family members, but certainly there's so many reasons that a patient's family can experience the death of a loved one, and I've just put a reason, a list on the screen of multiple reasons why somebody might find or I guess have significant grief after a death of a loved one, and very much by trying to, I guess, make a good plan for somebody's terminal care, by providing good symptom relief, and to make the care as smooth as possible. It's really helpful for families, and I feel that by achieving a good death, we help with families' bereavement. And that's all from me today. Thank you so much.
Thanks, Olivia. I feel like you've condensed years of learning and wisdom into 15 minutes. And we understand that there's a lot there, but I mean, Olivia has managed to summarize it brilliantly, I think, certainly for what you need to be thinking about around terminal, care in the terminal phase. And as I've said in the chat, we will be putting up these resources on our website and sending them out. So, I realize there's a lot of stuff going on. Now, one of the, Olivia made a comment about advanced care directive, 7-step pathways. Chris Moy will be, I think Chris Moy is going to be along in one of the future sessions to talk about that. One of his pet projects over many, many years has been developing that 7-step pathway. So we'll be talking a little bit more about that. I am aware that it is now just after 7:25, so my understanding is this session is supposed to finish at 7:45. Is that correct? So there are a couple of cases, but because Dr. Sue Haynes, who's a palliative care specialist, is online with us, it might be, and she's got some specific knowledge to impart around COPD. It might be better if we do the COPD case and just see how we go. Is that all right, folks? Were there any burning questions before we present possibly the only case we've got time for tonight?
We can do Donna next one.
Yeah, and next time. So Donna, I'm sorry, we might have to
Great.
we might have to leave yours till
It'd be great to be able to do that
next month, and sort of make sure we do that then. Any questions? Anything in the chat? Anybody want to ask before we? Okay, so we're going to put the case up on the screen. Oh, here we go.
Lovely. If you can just flick down, Olivia, thanks. I'm going to race through pretty quickly. So I guess that these slides are taken pretty much out of therapeutic guidelines, and you're very welcome to them. So I will literally race through them. I think just a few key points in regards to management of dyspnea. We've got the non-drug options, and we've got drug options. And we need to emphasise that the non-pharmacological interventions for managing dyspnea remain the mainstay of management. So when you were talking about the less severe end of the spectrum, or people who've got a stable sort of disease, things like handheld fans, which I think Olivia might have touched on last week, learning things about posture and physio intervention for things like teaching people diaphragmatic breathing, and managing activity and pacing activity, things to prevent severe episodes of dyspnea remains your mainstay of management. Pulmonary rehab for those who are earlier phase disease, who have been shown to very much benefit from this in terms of reduced fatigue and reduced symptoms. Thanks, Olivia. So those are the non-drug options. We did talk a little bit about the fact that we obviously need to do a detailed diagnostic workup to consider whether people have got anything that can be improved upon. However, we are recognising now that people who've got advanced cardiac failure and advanced lung disease, there is a baseline at which you've got this remaining syndrome of breathlessness which can be disabling despite maximising or optimising those therapies. And that leaves us with these other things that we need to think about, these, if you like, breathlessness-directed interventions. Thanks. So it boils down to drug treatment. Now, oxygen's a drug, we've got to remember that. So if a person's hypoxic, oxygen has a place. If people are not particularly hypoxic, then it's been shown really not to be that beneficial, and probably good airflow is as good as. There has been some studies done on just using air via nasal specs being beneficial in these situations. And then it boils down to basically opioids and benzodiazepines. Thanks, Olivia. I won't run through these in too much details, because you can, like I said, that's straight from therapeutic guidelines. You can go back and have a look if you're really interested in how you might start using opioids for dyspnea in their very acute phase and in the not so acute phase. But I'll just skip on to the next one, probably the next couple actually. No, that's good. Just to be aware that it's only a couple of years ago that the TGA in Australia was the first jurisdiction in the world to extend a licence for morphine for the treatment of chronic breathlessness, and that was in the form of slow-release Capanol. Thanks. So what is the evidence, and how do opioids work, and what do we know, and what are the gaps in our knowledge, and what are the risks? I'm just going to refer you to, if you can flick on please, to a very lovely study that came out in 2020 by Miriam Johnson in the UK and David Currow, who probably you know of. And I'll make sure that you get a copy of this. It's a fantastic summary of the evidence as it stands for opioids in dyspnea, very readable too. If we can go to the next one, Olivia, they give us a couple of lists of the summaries. So we think that opioids, we know that endogenous opioids modify the perception of breathlessness. There is evidence for a central modulation being the dominant mechanism, if you like, for how opioids work in modifying breathlessness. So they reduce the sensation or urge to breathe through cortical mechanisms. Very interestingly, this is a really interesting and important point to keep in mind. The response to opioids is reduced by impaired affect, like anxiety and depression, in the same way that response to opioids with pain is impaired. So a really important point to keep in mind. There is some evidence that opioids might modulate anticipatory breathlessness as well as the sensation of breathlessness itself. So people who get very anxious about the fact that I'm about to go and I need to go to the toilet and that's going to make me breathless, there is some evidence that the opioid actually helps with that anticipatory breathlessness as well. And obviously, just as there is with pain, inter-individual variation in the response to opioids, and that might be to do with affective state or just the pharmacogenetics of that person. Thanks, Olivia. So in terms of summarising the evidence of their effectiveness, there's level 1A evidence for effectiveness for breathlessness. Most of the evidence actually exists in people who've got chronic obstructive pulmonary disease. Now, the largest randomised trials use regular low-dose sustained release morphine de novo in opioid-naive participants. What has been found is that opioids are most effective for dyspnea once they reach steady state, rather than where you have somebody using a PRN dose of morphine syrup intermittently. It's really once you get them onto a background of, MS Contin or Capanol. I don't want to sort of be advertising any particular brands, but a slow release, steady state morphine, you expect to see a maximal benefit at about 5 days. There is some evidence around using the PRN opioids preemptively for exertion-related breathlessness. That's gone out of favour a little bit, sort of in the perhaps earlier phase, people who might have, a few years to live. There are concerns around the safety of using PRNs in that way because of the peak of opioid falls risk and all of those things. So just, in the UK, I think it's pretty much out of favour in terms of PRN usage of opioid for breathlessness in that way. They really favour and stick to the slow release form. Just to be aware that not all disease states seem to have breathlessness which responds to morphine. A little bit about that later, but in particular, I think people with certain types of pulmonary hypertension were found to not respond at all and to actually be made a little bit worse overall with opioids. And also importantly, not all opioids show reduction in breathlessness. So it's not a class effect. The opioids that have got the best evidence in dyspnea are morphine and fentanyl. We think, probably more anecdotally, that hydromorphone is equally effective, but there is no signal of benefit with oxycodone, interestingly. Okay, we don't know a lot about the long-term use as yet for opioids in breathlessness. Thanks, Olivia. Again, interestingly, what we find is that those people who've got end-stage lung disease with baseline breathlessness, the vast majority of them will respond to very low doses of steady-state morphine. 70% of responders responded at 10 milligrams per 24 hours orally. And a few people required escalation up to 30 milligrams over 24 hours. And very interestingly also, you can meet people who've been on these same doses for months or sometimes a year or two. So it's not the same story as we seem to see with either chronic pain or malignancy-related pain where you'd expect an escalation. They seem to do very well on a very low baseline. Respiratory adverse effects appear to be minimal, especially when you're using regular sustained release morphine. And clinically relevant respiratory depression has really been limited to very, very single case reports. And those have been in situations where people were not monitored properly. I guess importantly, placebo-controlled trials report no excess serious treatment emergent adverse events in the morphine arm. And I think it's taken a long time to get to that point, because I remember the early days of when we started using morphine for dyspnea maybe 15, 20 years ago. There was quite a lot of pushback from a lot of respiratory physicians who were very concerned about the respiratory depressive effects of morphine. So I think we have pretty good evidence now that that is not really that much of a concern when we're using it judiciously and in steady state. When we do see adverse events in that context, they're generally mild, and they're things like constipation, nausea and vomiting. And most of the nausea and vomiting is generally self-limiting. We generally cover people with antiemetics. Constipation, if you're on an opioid, you need to be on an aperient. That's a lifelong side effect. There perhaps is a little bit of an excess in adverse outcomes in people who are likely to have fluctuating renal function. So that might be seen more commonly in the patient with end-stage cardiac failure. There is some evidence for use of opioid in that group, but they probably need to be monitored a little bit more carefully given their propensity to dip into impaired renal function with decompensated cardiac failure. And leads us to that question about whether we might be using an alternative to morphine in that group. Thanks, Olivia. Okay, I think we've probably covered all that. Keep going. Do we have 3 minutes just to run through a couple of cases? Because
you have to poll everybody. That's fine. Go for it.
Good. Look, I just wanted to put just a couple of it, and these are all cases from this year because I'm doing a project currently which is looking at supporting primarily rural nursing homes that don't traditionally have that much input from palliative care specialists. And these are cases that we've discussed in our what we call our palliative care needs rounds, or monthly discussions with the GPs and the nursing homes, because I still get surprised that how well opioids work sometimes in this group of patients. So this was a man we discussed who'd he'd been living alone, oxygen dependent COPD, but he really just got to the point where he just couldn't manage. He'd had multiple PEs a couple of years ago. He'd had a funny looking lesion on his left lower lobe, but he'd refused to have that investigated any further. His renal function was okay. He'd had a few episodes of exacerbations of his COPD since moving into the aged care facility. He was generally declining. Interestingly, though, when he was admitted, he'd put down his goals of care as wanting full measures. And anyway, we discussed him at a needs round with, it wasn't his usual GP. The poor GP had been covering for the weekend when this guy suddenly became very unwell, hypoxic. And at that point, he was saying to the doctor, I just want to change my goals of care to comfort measures. In fact, I just would really like it if you would just, inject me so I died, because I'm so fed up with this. So, his poor GP was on the weekend, struck a bit of a compromise with him and said, look, we're just going to do best supportive care in the residential aged care facility. And then, when you're feeling a bit better and things are a bit more stable, maybe rediscuss your goals of care with your usual GP when he's back next week. So if we just flick on to the next slide, thanks. So he'd stabilised from that exacerbation, but he'd sort of declined functionally, as is usually, as Olivia may have talked about this, the deteriorating sort of phase that we see with chronic conditions. So he had more dyspnea at rest. He came through that bad episode, but he was worse overall. His usual meds really were very few, and I think the pregabalin was related to some peripheral neuropathy. He was on his usual puffers. He was using a little bit of endone PRN for various aches and pains. So we thought that he might be a good candidate with his good renal function to start him on some baseline morphine, to just basically initially substitute that endone out for some morphine TDS to QID, just for a trial for a day or two to make sure he was okay with it. And then once he'd done that for a day or two, the GP put him on to 10 milligrams of, it was a slow 24-hour slow release, that would have been Capanol. And when we talked to him about, after about a week or two later, he was mobilising more, he was much happier. So just with that one intervention, it'd been quite a remarkable turnaround for him. We'll just flick on to the next one. Another lady is 72. She also had severe oxygen dependent COAD. She also had a background of CCF, a bit of cognitive impairment, ischemic heart disease, anxiety, history, hypertension, osteoarthritis, blah, and crush fracture. So she was mainly troubled though by significant dyspnea at rest. And she would hardly go to bed because she was so dyspneic, so she found it more comfortable sitting up. And that was creating other problems with terrible pitting edema of her legs and vascular insufficiency, and the legs would get very discoloured and weepy, and her GP lamented that often she would come back from a weekend of not being on call to find this lady being put back on yet another course of antibiotics for cellulitis. So that was, another issue for her. So there's a balance going on with her furosemide and spironolactone to try and best control her CCF symptoms. She was on a bit of Targin for musculoskeletal pains. And she'd actually been tried on some morphine, because we talked about morphine with this group of GPs before. So she'd been taking a little bit of morphine liquid twice a day for a dyspnea, which she'd actually found quite helpful. So if we flick on to the next one, I think it relates to this one. No, sorry, it doesn't. Just keep flicking. I don't know what happened there. Sorry, I lost that. I'll just have to talk about her. So she also started on some Capanol and was significantly improved after a week or so. Was able to get to bed, which meant that she could elevate her legs, and therefore the legs were much better. So it had improved her quality of life, her sleep pattern dramatically, and she was much happier. So yeah, as I say, I still get surprised with how well just a very low dose of opioid can work. If we have 1 minute more, if you'll bear with me, I just want to make a point about benzos and dyspnea. We do use them. They're not first-line drug for dyspnea, as they do increase the risk of falls and morbidity and mortality. They don't relieve dyspnea as such, but they do have a role when that anxiety is a big part of what you see with dyspnea. Again, just some therapeutic guidelines, recommendations there, but I'll get you to flick on to the next one, Olivia. I guess the thing is that if you do find that dyspnea does respond well to the addition of benzos, then we need to consider a more definitive medication and non-pharmacological interventions for a patient's anxiety. And that might be, as you well know, antidepressants, first line for severe anxiety when the prognosis might allow for that. Or if you're looking at a shorter prognosis, then you might be happier to use the benzos in that context. And I might just stop there and see if anybody's got any questions.
Thanks, Sue. That was fantastic. Really impressive presentation and a lot of really practical advice too. And again, you know, the power of morphine for dyspnea, hey? Yeah, I think sometimes people get surprised at that, but it does certainly work with some people. Has anybody got any questions? Anything they want to put in the chat? No? And so I appreciate the fact that we've gone a little bit over time, but I think it was well worth it because Sue's presentation was fantastic. So I'd like to thank everybody for joining us tonight. And you know, hopefully this is the second echo session. Hopefully it'll become smoother each time. And a huge thank you to our. Oh, okay. So there is a question. Yes, I've just spotted that. This is from Jennifer. You mentioned about oxygen, presumably via nasal specs. How can I organise that in the community? Where? Yes. Where, Jennifer, you're in a metropolitan area?
That is a good question, and I might just defer that one to Olivia.
Yeah, I think really, I guess if it's, you know, if we agree that this patient requires oxygen, then an oxygen script needs to be written. And then the way I usually do it, and I appreciate that I'm working out of a hospital, but then the script is sent to a company such as Respirico, who provide the equipment, the oxygen, the cylinders, and also the nasal cannula as well.
Yeah.
So
I do appreciate Jennifer. Sorry, Jennifer's question was about air.
Yeah, so
that's a good question there. And my, sorry, I probably misled you a bit there. My understanding is that that's been more an experimental thing to really try and tease out the, you know, the, if you like, the placebo effect of oxygen. A good way, I think, of trying to replicate that in the community is the old handheld fan or the pedestal fan, just to get airflow. I'm not really aware of you being able to get medical air. Are you, Olivia?
No, I'm so sorry. I miss.
No, irrelevant.
Thank you for that clarification. I've not used it. Certainly lots of use of handheld fans, but not via nasal specs.
Yeah. Okay. Thank you for that.
Great question.
Yeah, good question. So special huge thanks to our presenters tonight, Paul, Olivia, and Sue. Really appreciate your time and your wisdom, and to the GP who provided our case tonight, which led to lots of very useful information presented by Sue. So thank you very much. We would love to get your feedback. So please fill out the feedback survey when we send it to you. And as mentioned, and I've sort of put it in the chat too. Oh, Jenny has raised her hand. I'll just finish this. You will get a recording of tonight's session. And so that has all the tasty, useful bits in there that have been presented. Our next session is on Wednesday, the 12th of October, and the focus will be on palliative pharmacotherapy. So it's probably some overlap with some of the things that are being presented. So is there a hand up? Is that what somebody said? Oh, okay. Thank you. Thank you, Jenny. So the other thing I want to add is, you know, that was a really useful case. We've got another one in the wings waiting, but please send in your cases because it's an important part of ECHO, not just the didactic presentations, but having cases and being able to discuss them. So we've attached a copy of the case submission form in the chat. Thank you very much. And we look forward to seeing you at our next session. Thanks, everybody. Thank you. See ya.
Good night.
Bye-bye.